diagnóstico y el manejo. We're going to talk about the diagnosis and management of peripheral arterial occlusive disease. As I said before, this is a situation, a pathological situation in the United States that affects many people. That's approximately 8 to 12 million Americans. So if the positive risk factors prevail amongst these patients, 29% of them will develop these conditions. That is, if the patient has hypertension, diabetes, et cetera, within their conditions of medical problems. Patients are also known to have a coronary artery disease in about 30% of patients. You think, wow, these patients with peripheral vascular disease, you know, they should have vascular disease everywhere, not just in their legs, but they should have them in their heart or in their brain. The reality is that patients with coronary artery disease, you know, just a small subset of these patients will have peripheral vascular disease or will have coronary artery disease. These patients obviously have a risk for myocardial infarctions because of the risk, stroke, and also vascular death over the 5 years of their course. So how do they present? Many times these patients come to the office and they're completely asymptomatic. That's why it's so important for the clinician to be aware of the conditions that lead to peripheral vascular disease. A good clinical examination is of utmost importance. Early identification of the problems will definitely save people's limbs and also will save their lives. Remember, if the patient doesn't have mobility, if the patient is bedridden, the patient is not very mobile and is just a couch potato, all they're looking for is other problems to occur, whether they're going to lose their leg, they're going to have a stroke, or they're going to have a myocardial infarction. So the reality in our country, here in the United States and worldwide, is that this pathology is poorly taught. Okay, that goes throughout all the specialties, except now vascular surgery and cardiology, which the reason we are so in depth in our knowledge of this disease is because this is what prevails and this is what we start to treat. And unfortunately, many times these patients come at the last, you know, they come to us as a last resort for their treatments. So the clinical examination many times in the patient's primary care office it's negligible. They do not check the pulses. They do not, you know, do a good vascular examination. So who's affected by this? Elderly patients, just like I said, you know, patients over the age of 50, although 50 is not elderly, but, you know, when we get to the 60s and 70s and 80s, you know, the disease is more prevalent and it's more difficult to manage. Patients with coronary artery disease, you know, you have to search for, you know, for these individuals, you know, that fall under the 20 to 30% of the prevalence of peripheral vascular disease. Smokers, diabetes, patients with end-stage renal disease, patients with hyperlipidemia, and then a family history of having these conditions, hypertension, and unfortunately, the male sex is affected more than the female sex. The anatomy is vast that is affected by the atherosclerotic disease. This is just a quick overview of what you already know. When we do a patient's examination and their chief complaint is leg pain, we have to differentiate that type of pain from vascular pain, musculoskeletal pain, and neurogenic pain. Knowledge of physical examination is very, very important, because if you cannot make a good physical examination and your knowledge of how to perform that isn't there, then you're not going to come up with a diagnosis. You're going to confuse neurogenic lower extremity pain with musculoskeletal pain. If you have a 25-year-old athletic patient comes into your office and they have acute onset of left lower extremity pain after playing a sport, you're not going to think this patient has vascular disease, right, Julia? Right. So you do a thorough examination, you examine the patient. Yes, you check for pulses. Not to say that that young athlete may not have a arterial dissection that cause loss of arterial flow, but it's probably not likely. So your clinical examination is very important. Doing a good neuro exam during a good inspection of the patient, assessing for a swelling, ecchymosis, et cetera, et cetera. Vascular patients, when we look at them, we look at the arterial side, we look at the venous side, because the lower extremity pain may be associated also to a deep venous thrombosis, which I'm sure you guys are familiar with DVTs. Arterial conditions are usually very abrupt, you know, in younger patients. And older patients, they can be abrupt or acute, or also they can be chronic. These patients have had pain for a long period of time and it's just getting worse. And their major complaint is, oh, I can't walk very far. I walk a block or a block and a half, and then I have to stop and rest, and then the pain goes away. And that is called claudication, right? But claudication is a term that we use to describe a symptom that we can not just use for the arterial side, but we can also have venous claudication. And I'll explain that to you guys in another topic down the road. Musculoskeletal, muscle injury, arthritis, tendinitis, all these things can cause pain that's really localized and can be exacerbated by locomotion, or it could be pain at rest. So understanding the way that the pain presents is very important. Pain at rest is very different than pain when moving. Pain that occurs at the end of the day is different from pain that occurs early in the morning, et cetera, et cetera. I hope I'm making myself clear with this. Anybody have any questions so far? Okay, very good. All right, so let's move on. And we've talked about claudication. So claudication is pain usually in the calf, right? Depending on the level of the vascular condition, the level of the vascular either stenosis or blockage. You can also have buttock claudication, and there is a syndrome called Leriche syndrome that gives you buttock claudication along with impotence in males. And that's associated to a blockage up in the pelvic area, associated to the common iliac artery, which decreases the blood flow into the internal iliac artery and external iliac artery, affecting the gluteal muscle arterial perfusion. So if you're not getting enough blood flow and you're walking and your glutes are requiring your gluteal arteries to be perfused and they're not, you're going to walk for a little bit, your gluteal muscles are going to require more oxygenation and you're going to have to stop because you're not going to be able to move. So that's buttock claudication. Limb-threatening ischemia. So we talked about patients with pain at rest. Yeah, well, patients with pain at rest, yeah, it could be a neurological injury, a spinal stenosis. There could be a lot of things, right? But if you have a patient who comes to your office and never smoked, doesn't have high cholesterol, right? Doesn't have diabetes, is relatively healthy, and they start to have pain in their legs at rest, it's not going to be a issue with arterial flow. It's going to be an issue with a neuropathic issue, a neurological issue, a lower spine issue, you know, or an acute injury. But if you have a patient that comes to your office, right, and you see them and they're all wrinkled up because they've smoked their entire life, okay, they have a raspy voice and they smell and reek of cigarette smoke, you know, and they come in and they have rest pain and they have an ulcer or even gangrene, you're going to be suspicious that that patient has profound critical limb ischemia, okay? So those are the symptoms. Claudication, again, pain. Patient can walk up the hill and versus flat, and they say, oh, I can't really walk up the hill because I get pain in my calf or I get a vice grip. The pain is usually described as a vice grip grabbing onto the calves, and then they have to stop because they can't move, and then the pain subsides. And do you guys understand why this happens? Let me pick on someone here. Genesis, what do you think? Why do you think that happens? Why do the patients feel like they have a vice around their calves, a vice grip?
A what, sorry?
A vice grip. A vice grip is es como una what's how you say a vice grip in Spanish?
Vice grip.
Yeah. Es una prensa, es como una prensa, es una prensa, no, se siente como alguien te estaría apretando, ¿no? La musculatura de tu pantorrilla, ¿no? Donde están tus gemelos. Eso es como se siente cuando una persona está teniendo claudicación. Es como si le estarían apretando, you know, yeah. It's like a vice grip on your calf.
Ok, es como debido a que se está provocando un tipo de isquemia, esta va a producir el, por terminación nerviosa y la vasoconstricción produciría dolor.
Bueno, lo que está pasando, primero en los pacientes con enfermedad periférica vascular, ya en sí ya tienen una vasodilatación crónica. Pero esa vasodilatación crónica se debe a una insuficiencia arterial. Cuando pasa, lo que pasa es que si hay una obstrucción o una estenosis en la arteria femoral superficial, ya sea proximal, medio o distal, pues esos pacientes pueden tener una isquemia, ¿no? De los gemelos por falta de insuficiencia. Entonces, cuando aumenta la movilidad de ese paciente, ¿no? Hay un aumento de la demanda de oxígeno, ¿no? A través de los glóbulos rojos que traen oxígeno a los tejidos. Entonces, ese paciente va consumiendo todo ese oxígeno y de repente ya no puede más porque está empezando a tener una insuficiencia arterial. Y eso es lo que se traduce como claudicación. El paciente para de caminar, entonces después de parar de caminar, y lo que ya abastecía cuando uno está descansando, pues regresa, ¿ok? Y eso, y la claudicación, dependiendo de dónde es, ya sea si es en la pierna o en el muslo, te da una pauta de a qué nivel está la obstrucción o la estenosis arterial, ¿ok? Y es bien consistente. It's very consistent and it's reproducible. Si tú agarras a un paciente, lo pones en un laboratorio vascular, ¿no? Un laboratorio de ultrasonografía vascular, y haces que el paciente camine en un treadmill, ¿no? ¿Cómo se llama un treadmill?
Una caminadora.
Una caminadora. En la caminadora, pues el paciente en cierto tiempo y cierta distancia va a tener ese síntoma que le va a hacer que tenga que parar de caminar. Entonces, ahí se puede medir la distancia, ¿no? A claudicación. Is that understood? Okay. All right, so I'm going to continue. Entonces, la claudicación es consistente y se puede reproducir. Okay. All right. Vamos a continuar. Y el rest pain, this is pain at rest, obviously, right? These patients, this is like the classic thing that you learn in med school, you know, patients at rest that have to hang their legs off the bed to alleviate the pain, or they have to sit up or stand up so the pain goes away. It's the same principle. Patients with profound critical limb ischemia don't just have proximal disease, but they also have infrapopliteal disease. Debajo de la popltea, las arterias tibiales también están afectadas. Este paciente ya no debe tener 3-vessel runoff. This patient probably has 0 vessel runoff, and they're on their last limb before they lose their leg. Okay, so rest pain, usually and often at night or when laying flat. And it's more distal pain, pain that's associated to the feet, the toes, the ankle, not really the calf, okay? And it's relieved by walking or standing up. Gravity is pulling. You guys remember from your physiology, hydrostatic pressure, right? So when you stand up, that water is being pulled by gravity down. So 80% of blood is water. So that element's being pulled down, facilitating the red blood cells to get to those small vessel beds, capillary beds to get them blood flow. All right, so on your evaluation, you have to inspect the patient. Patients with peripheral vascular disease usually have a loss of hair. Now, a loss of hair in the legs is not just associated to poor vascular flow, but it's also genetic. And it also occurs as we get older, as a normal finding, even without having vascular disease. Capillary refill, if you look at the toes, usually in a patient with critical limb ischemia, what you see is that their feet are bright red, okay? They're bright red. And let's see, Wilma, what do you think, why would the feet be red in a patient with peripheral vascular disease?
Well,
pressure caused by like the blood circulating in the area, and if they have claudication, doesn't the blood stay in that place instead of having like return to the heart?
Well, it doesn't stay there, right? It does return to the heart. Now, when you look at someone's feet, okay, have you seen a person's feet turn purple? Okay. So what do you think would happen if the blood stays there longer than it should? Would it be bright red or would it be purple?
It will be purple
Of course. And why is that?
because it starts to coagulate.
No, no, no. It doesn't coagulate. It doesn't coagulate. What happens to the blood when it's exposed to the capillary beds? What exchange happens there at that level with the capillaries?
CO2 with oxygen.
Correct. So if you have a noose around your neck, you're going to turn purple, right? Not because you're clotting up, but because the oxygen is being extracted from the red blood cells. So you turn purple because your hemoglobin gets deoxygenated. Now it's carrying CO2 and it's not carrying oxygen. So hemoglobin changes color, it turns purple, right? So what happens in individuals with peripheral vascular disease, they have a pathophysiological response of vasodilatation. There is vasodilatation in the small capillaries that allows that patient who's got arterial insufficiency to get as much blood flow as possible, and the body takes care of extracting that blood from there, right? So patients who have bright red feet that have underlying vascular disease, they have compensated by vasodilatation. And the red discoloration of the feet only happens when they're pending, when the foot is hanging. If you take that foot and you elevate it above the level of their heart, you know what happens to that foot? It turns pale white. That is called rubor dependency. Okay, rubor dependency is when your leg is hanging, it's bright red, but if you lift that leg up and it blanches white, it's because there's not enough blood flow getting there. Gravity is helping when it's hanging, but when it's flat or when you elevate it and it turns pale white, that's an indication that that patient has critical limb ischemia. Okay, a dependent rubor. And you can use that test when you're in your office and you're looking at a patient. You say, wow, the patient's feet are red, but you touch them and they're kind of cool to touch. Sometimes it can be warm, but sometimes they're usually cool. And when you lift that up, the foot turns pale white. Okay, so pending rubor, okay, or rubor dependency. If it's cyanotic or the leg is ruberous, I've already explained that to you. If there's edema, swelling, there is an issue with swelling, right? Swelling could be a problem with the heart. Your heart's not, your ejection fraction is low and you're having right-sided heart failure. That you have to associate with the patient's, medical history, et cetera, history of congestive heart failure, history of global heart failure, what medications they're on, et cetera, et cetera. If the patient has had a echocardiogram recently, understanding the cardiac dynamics is very important. But edema usually does not occur in patients with critical limb ischemia, not unless they have an ongoing venous condition or a right-sided heart condition. Okay, most patients, they'll come to you and their legs will look very, very thin. The skin is very thin. The nail ridges are very thick. Okay, so if you look at them, they kind of resemble the nail ridges of a patient with a fungal infection. All right, they're very thickened nail ridges, they're deformed, et cetera. And that's because those nail beds have had chronic hypoperfusion, chronic ischemia. Okay, so they grow abnormal. You can have a patient that will develop cellulitis. Most of these patients with vascular disease, they come to us because they were seen by podiatry. The podiatrist examine their feet, and since they love to nip and clip and cut, they decide that they're going to work on the toenails, and all of a sudden they get too close to the skin and make a small nick in the skin, and these patients now have an opening for bacteria to come in. And because they don't have good perfusion, they're not going to have their army of white blood cells down there attacking the invaders, and the skin's going to get invaded. They're going to develop cellulitis, and they progress to ulcers, and then, you know, to gangrene, unfortunately. Okay, so in the inspection is very important. You look, you see, you touch, you smell. You know, you can smell an infection. When you look and you see a bright red foot, you should think, oh, maybe this patient has pending rubor. I'm going to do a pending rubor test, et cetera, et cetera. And then obviously, you know, then you go to palpation, right? You want to palpate all the pulse areas, the groin, the popliteal, the dorsalis pedis, the posterior tibial, et cetera, when the patient is sitting in supine, because it'll make a difference if the patient is sitting or the patient is laying flat. Okay. A Doppler examination is very important. And never forget, when you're talking about pulses and Doppler signals, to know the difference. I don't know how many times I've seen people, even physicians who are not vascular surgeons, take a Doppler probe and listen to a Doppler signal and say, yeah, the pulses are present. Juliette, do you know the difference between the pulses and the Doppler signals?
No.
Okay,
Sorry.
so pulse is a pulse you feel, right? If you take a Doppler, you're not feeling the pulse, you're listening to it. You're listening to a signal. So that's the difference, okay? Doppler signals, yeah, and they come in 3 flavors, all right? Or actually 4. Non-present is one. Triphasic Doppler signals is when you can listen to a triphasic signal, which sounds like, okay? Or you listen to a biphasic signal, which sounds, or you listen to a monophasic signal and it sounds, okay? So when you look at a waveform, you know, for a Doppler signal, there's triphasic, which is normal. There's biphasic, which can be kind of normal, but really it's not normal. And then you have a monophasic, which is definitely abnormal. And as you get, you know, to that point where they're decreasing in amplitude, you know, then the waveform sounds different. You know, the sound sounds much lower. So don't ever confuse Doppler signals with pulses, okay? So let's see, clinical findings suggestive of PVD, obviously decreased pulses. And if you examine your patient well, you should be able to identify where the issue is just by palpation. How the femoral pulse is compared to the left and right, the popliteal pulse, always comparing both sides, the dorsalis pedis and the posterior tibial. There's a third vessel in the leg that's very difficult to palpate, but sometimes you can, but most of the time you can Doppler. You guys know which vessel that is? Jonathan, are you in the medical class with us too, or you're just the tech that's helping with the Zoom meeting? Aparicio.
Perdón, no entendí la pregunta.
Preguntaba si eras parte del curso, de la clase, o era simplemente para ayudarnos con la parte técnica.
Ah, no, sí, yo soy parte de la clase, sí.
Ya, perfecto. Entonces, esto te preguntaba porque no estaba seguro. No estaba seguro. Entonces, te pregunto, Jonathan, en la pierna, en las piernas existen 3 arterias, ¿no ve? 3 arterias, ¿no? Y había dicho que 2 se pueden sentir. Y la tercera, ¿cuál es la tercera que no se puede sentir muy bien, pero se puede usar un Doppler?
La femoral interna.
No. Juliet, ¿cuáles son las 3 arterias de la pierna?
La arteria femoral, la arteria tibial y...
Ok, son 3 arterias, ok. Vamos a empezar de arriba rápidamente y les voy a volver a explicar. Ok, a partir del ligamento de Pupart, ¿no? Del ligamento inguinal, tenemos a la arteria femoral, ¿no ve? No solo el ligamento nos sirve como delimitante, pero también la arteria epigástrica superficial. A partir de la epigástrica superficial se conoce como la arteria femoral común. Se divide en la profunda y la superficial, ¿no? La superficial hace su curso por el muslo, ¿no? Y llega detrás de la rodilla. Y detrás de la rodilla, pasando el canal aductor, se conoce como la arteria poplitea. La arteria poplitea tiene 3 segmentos, ¿no? La P1, P2, P3, y después la primera rama que sale de la poplitea, ¿no? Cuando ya deja de ser poplitea, se llama la tibial anterior. La tibial anterior cursa por el compartimiento anterior de la pierna y llega hasta al tobillo y se convierte en la arteria pedia, ¿ok? The dorsalis pedis. Después, la poplitea debajo de la tibial anterior se convierte en el tronco tibio peroneal. Y tú habías dicho bien, Juliet, la peroneal. La peroneal es la arteria que no se puede palpar fácilmente, pero se puede hacer un Doppler a nivel del tobillo. Generalmente se encuentra entre la fíbula y la tibia, ¿ok? Y después tenemos la otra arteria que es importante, que sí se siente al palpar detrás del tobillo, que es la tibial posterior, ¿ok? Todos estos llegan al pie, ¿no? Y se convierten en ramas más pequeñas. Y eso quiero que ustedes lo vayan aprendiendo porque esas arterias son fáciles de aprender. Las de abajo del pie no las usamos tan frecuentemente, pero existen y necesitan conocerlas porque la dorsalis pedis se va conectando en un arco en el pie con las arterias que vienen de la tibial posterior, ¿ya? Que son las plantares, que las van a conocer y vamos a hablar sobre ellas cuando estemos hablando de técnicas de salvar el pie, ¿no? Y salvar los dígitos del pie. Ok, entonces, ¿qué más vemos nosotros en enfermedad periférica vascular? Vemos atrofia muscular. Obviamente, porque hay una hipoperfusión sanguínea, va a haber atrofia muscular. So this muscle atrophy is associated to the lack of use of that lower extremity because the patient can't walk anymore. Can't walk too far. And so this patient's going to have muscle atrophy. They're going to have hair loss. And then they're going to have nail changes, as we talked before. Dependent rubor, as I mentioned, and then in later stages, as this progresses into critical limb ischemia, the patients will have ulcers and gangrene. So classification of PAD. So there's 2 authors that have made a classification of peripheral arterial occlusive disease, okay? And that is Rutherford and Fontaine. Okay, Fontaine says that there are 4 different stages of vascular disease. The first stage is one that's completely asymptomatic, okay? And these are patients that by ultrasound, you're going to find that they have some intimal medial wall thickening and signs of atherosclerosis, but not significant enough to give you any symptoms. The stage 2A and 2B, these are 2A, mild claudication, which you guys understand already what claudication is, and then moderate to severe claudication. Stage 3 is ischemic rest pain. It's that patient that has severe atrophy, skin changes, thickened nail ridges, and a bright red foot, okay? Or maybe even a pale foot with some red tinges. And we talked about capillary refill, right? So when you guys do a capillary refill in a patient with rest pain, that capillary refill is gonna look normal, okay? It's gonna look completely normal. Unless you elevate that leg above the level of the heart and check that capillary refill, it's gonna look normal to you. So don't get fooled by the red looking foot that you push down on the nail bed and it blanches and then it comes back, okay? Because that's not gonna really help you. Ischemic rest pain, pending rubor, okay? And the stage 4 of Fontaine is the presence of ulceration or gangrene. Rutherford is a little bit more complex, and it's very similar. So we've got, it comes not in stages, but in grades. Grade 0 is asymptomatic, right? Or grade 0, category 0. Grade 1 or category 1 is mild claudication. Grade 1, category 2 is moderate claudication. Grade 1, category 3 is severe claudication. And then you come to, for grade 2, category 4, which you have ischemic rest pain. Grade 3, category 5, minor tissue loss. In grade 4, category 6 is when you have ulcerations and gangrene. You can use either or, but the most important thing is not to memorize this, but to understand it, okay? This is good as a method of nomenclature when you are documenting your patient's findings, all right? Any questions here? All right, let's go to, there's another classification that Rutherford has, and it's for acute limb ischemia. Acute limb ischemia is very different from just your everyday peripheral vascular disease and all the categories or stages, okay? And the reason that I put this in here is so we don't confuse these classifications. ALI, acute limb ischemia, is when the patient comes in with a very threatened, immediately threatened limb. They come in with rest pain that does not subside even with hanging the leg, okay? They start having numbness of the leg. They start having loss of function in that leg. So let's look at this. So when a patient comes in, okay, there's 3 categories. The first category can be a viable limb. There's not an immediate threat, okay? And a lot of these patients will come with this, that all of a sudden they have acute onset of pain and the pain gets better, but they come into the ER anyway. And you do a clinical examination on a category 1, and there is no sensory loss, there's no muscle weakness. There you can hear the artery by Doppler, and you can also hear the vein, an audible vein. Audible vein by Doppler is a continuous flow, okay? That is phasic. When I say phasic, it varies with respiration, okay? Do you guys understand that? See, the arterial blood flow is pulsatile, right? And there's a waveform in the arterial blood flow. The veins also have a waveform, but it's very different than the arterial side. So just remember your physiology, so you can understand this. When I listen to a vein, you can listen to a continuous flow in the vein. It's very different. You can augment that by squeezing the foot or squeezing the calf as long as your probe is higher up, right? More proximal to the body. Then you can squeeze and you can listen to this sound. It sounds like this, right? You guys have heard that before, right? Right? So that is called augmentation. And phasicity is when the patient is taking a breath and you can hear that flow just going, okay? It's not really a pulse. It's variability with respiration. All right, let me stop digressing here. So category 2, now we're coming into a threatened limb, okay? And there's a category 2A and a 2B. 2A is marginal, so salvageable if promptly treated. All right, this is a limb that you're going to get kudos if you find this for your attending while you're on call, because you're going to be able to save this patient's leg, okay? Sensory loss is minimal. There is no muscle weakness. You can often hear an arterial pulse. Usually it's monophasic, but you can hear it, and you definitely hear a venous flow, okay? A 2B, this is immediately, okay? This is like, you have to revascularize that limb soon or the patient's gonna lose the leg. Salvageable with immediate revascularization. The sensory loss is more than just the toes. The toes, the ball of the foot, the dorsum of the foot, start to have issues. Muscle weakness, they usually have mild to moderate muscle weakness, and you always do a comparative. You compare both sides, right? Usually it's inaudible. You will not be able to hear a Doppler signal, okay? They come in with a pale foot, etc. You can still have a venous flow, but there's really no audible arterial flow. If you get a category 3, forget it. It's irreversible. So major tissue loss or permanent nerve damage is inevitable. You're going to have profound anesthesia. A patient cannot feel anything in the foot up to the level where the blood flow stops. Okay, there's profound paralysis. That patient won't be able to move that foot at all. You can't hear a Doppler signal, and there's no arterial nor venous signals, okay? So what happens if you are you know, this cavalier guy or girl, and you get a patient with a category 3, and you take him to the OR and you revascularize the patient's limb. Wilma, what do you think is going to happen if you get blood flow into that dead leg?
In a category 3, irreversible.
Yes, it's irreversible. What happens if you're a cavalier person and you wanna pretend you're Jesus Christ and you want to bring Lazarus back to life? What's going to happen to that leg if you try to open up those arteries that are blocked in that leg that's dead?
Nothing.
Probably nothing, but if you do get that to reperfuse some, you're going to get an influx of a mineral that can be lethal. And also you're going to have an influx of the breakdown of muscle into the bloodstream that could kill your kidneys. So what happens if you're revascularizing a limb, even a class 2B, if you're revascularizing a limb, you're going to revascularize a leg that went into lactic acidosis, okay, anaerobic breathing, okay, and you're going to lyse all the cells because you're bringing new blood flow in there and oxygen. And those cells that are dead, they're going to try to come back to life, but they're just going to be spilling hydrogen ions, acidity, and they're going to be spilling in potassium. So what happens if in hyperkalemia? If you have hyperkalemia, you can have an irregular heartbeat. You can actually put your patient in cardiac arrest. Make sense? And then the other thing is that you're going to have myoglobinuria because there is a rhabdomyolysis. So you got rhabdomyolysis because the muscles are dying, and then you're going to wash everything back into this to the patient. Now, it's very important not just to understand this classification, but also know when to operate and what to do. Even in a class 2B patient that you have to go in there and try to salvage it. If that patient has been in a class 2B category, more than 6 hours, okay, more than 6 hours, and that patient is getting close to category 3, usually in that lower limb, you're going to have to do a 4-compartment fasciotomy. The lower extremity in the leg, there's 4 compartments, and you have to relieve them because if you don't relieve them, the tissues will swell and will kill more muscle and destroy the nerves, and that limb will not be salvageable. And at the same time, you have to monitor your patient's potassium, renal function, and have to be aggressive to protect the kidneys and make sure that the potassium is well controlled. Okay, so that's just kind of a recap of pathophysiology that you guys might need to understand. All right, so clinical features. When these patients come in with ALI, acute limb ischemia, the pain is usually sudden. There is pallor, and the leg looks kind of waxy, okay? Pale, waxy. Even in us Latinos with darker skin, our feet look funny, okay? And they look pale, all right? Paresthesias, numbness, you know, pulselessness, and paralysis. So this is the 5 Ps of acute limb ischemia. 5 Ps: pain, pallor, paresthesias, pulselessness, and paralysis. And there is another one. There's actually a 6th one. It's poikilothermia. Poikilothermia is cold leg, okay? A cold foot, cold temperature. So there's more than 5, there's 6, but we'll stick to the 5. Any questions so far? No? Okay, let's move on. All right, so indirect physiological testing consists of pressure assessment. The easiest test that you can do on a patient, right, to assess the quality of their arterial blood flow in the lower extremity is an ankle brachial index. Have you guys heard of an ankle brachial index, Genesis? Yes, okay. All right, and then Doppler waveform analysis. So I have mentioned already 3 types of waveforms, right? Actually, the 4th, you don't have a waveform, it's 0, but the 3 is triphasic, biphasic, and monophasic, okay? Or now we're starting to use the term multiphasic, where you have patients with multiphasic waveforms. Segmental pressures are also a good test. They're cumbersome, it takes a long time, but the easiest test for somebody that's in the emergency room, and you have a patient with a suspected acute limb ischemia, or somebody that comes in with gangrene of the toes and you want to get a quick assessment, ankle brachial index is good. Ankle brachial index is a relationship between the brachial pressure and the ankle pressure, or the ankle pressure with the brachial pressure. You take the highest brachial pressure and you take the highest ankle pressure and you divide the two and you get a ratio. Okay. Usually the pressure in the ankles and the feet are going to be higher than the pressures in the brachia, and the reason is because of gravity. All right. So 1 is usually normal. Up to 1.2 is normal. And if it's higher than that, it starts to be an issue with compressibility. And then we talk about patients with diabetes and end-stage renal disease, where their media is so hard that you can't really squeeze it like you would a normal vessel. But then again, what vessel in the leg is normal in a patient with peripheral vascular disease? So there's another test, and I'll talk about that. It's called the toe brachial index. So ABI, bilateral ankle pressures divided by the higher brachial pressure. This is a depiction of what we do. So dorsalis pedis is the one on the top. It's easy compressible. It's harder to locate, but not really if you know your anatomy, usually between the first and second digit or first and second tendons of those digits. The posterior tibial, it's harder to compress because of the bony prominences, but you can locate it easier. It's also very easily palpated. It's important that you guys get into a habit of touching feet, okay? Feeling pulses. Feel your pulses, feel your classmates' pulses to understand and feel what a normal vessel feels like. And the more you feel, the more comfortable you'll get with your examination. So this is pulse volume recording depiction and the different levels. You can actually put cuffs at all the levels that you can see here, from the red, the light blue, the green, the darker blue, and the yellow, okay? The yellow, actually, you can't get a pressure off of that. I've never done a pressure cuff on that, but I guess you could. But it's important to understand that you can get waveforms throughout this, either by Doppler or plethysmography. So arresting ABIs, there is a difference between doing an ABI in a patient that is laying in bed and a patient that you've put on the treadmill for 10 minutes, okay? So if the patient's laying in bed, you do an ABI, that's called a resting ABI. So greater than 1.0 is usually normal. Less than 0.90 is abnormal. In other words, anything up above 0.91 would be considered in the normal range. Less than 0.8, patient may probably have claudication. Patient less than 0.5, usually it's multi-level disease, or there is a long segmental occlusion, usually of the superficial femoral artery. And the patient that has that rubor dependency or dependent rubor will usually have an ABI that's less than 0.4, okay, which translates into ischemic rest pain. So what's the bane of pressure measurements? Well, the bane of pressure measurements is the fact that some of these patients may have calcific medial sclerosis. What is that? Calcific medial sclerosis. That's when the media of that vessel, because of the patient's condition of diabetes or end-stage renal disease, has become hard, like a pipe. Not necessarily obstructed, but where an ankle brachial index will not be sufficient to come with a diagnosis, because you're going to get an abnormal reading. You won't be able to compress that vessel. You won't be able to make that Doppler signal disappear when you're compressing the vessel, okay? That happens in diabetes, chronic steroid therapy, renal dialysis patients. And the reason why renal dialysis patients have this condition, do you guys know why? Why do you guys think that renal dialysis patients, and it's not just because their diabetes led to renal dialysis, right, to dialysis, or their hypertension led to dialysis? A ver, who can I pick on? Esther. ¿Qué dices tú, Esther?
Tal vez es por la misma diálisis, el recambio de sangre hace que las arterias se endurezcan.
Pero sí, sí, tienes razón, pero ¿cuál es qué es lo que pasa? ¿Qué es lo que pasa durante la diálisis que hace que los pacientes tengan una predisposición a que las arterias se endurezcan más? En primer lugar, ¿qué es lo que causa que las arterias se vuelvan duras? ¿Qué es el componente principal de la aterosclerosis? ¿Por qué se ponen duras? Se ponen duras
Serían
como hueso, ¿no ve? ¿Qué tiene hueso?
los acúmulos de colesterol.
El colesterol, sí, pero el colesterol es mushy, es bien suavito. Es como un curd, el colesterol,
La fibrina,
¿no? ¿De qué están compuestos los huesos?
calcio.
Calcio. ¿Qué es lo que pasa en el paciente con diálisis? Le estamos extrayendo el calcio de la sangre durante el proceso de diálisis. ¿Qué es lo que pasa con las paratiroides en los pacientes con diálisis? Empiezan a producir más parathormona, ¿no? Parathyroid hormone, y aumenta la concentración de calcio en la sangre. Y algunos de los pacientes hacen una hipercalcemia terciaria, tertiary hypercalcemia, due to tertiary hyperparathyroidism. Entonces, se acelera el proceso de aterosclerosis y las arterias se vuelven más duras. ¿Ok? Es debido al calcio. ¿Ok? Pacientes viejitos, obviamente, elderly patients will have calcific medial sclerosis. The segmental pressures are unobtainable or excessively high. You can't really compress those vessels. And if you compress them at high pressures, okay? So in these patients, usually the small vessels, the tiny vessels are saved, and you can do what's called toe pressures. Any toe pressure greater than 40 millimeters of mercury is what you need for tissue healing, and anything over 20 millimeters of mercury for tissue healing in non-diabetic patients. So more than 40 and more than 20 of pressure in the toes will help either diabetics or non-diabetics with their wound healing. Don't worry about that. You know, when you look at a toe brachial pressure, if the toe brachial pressure is greater than 0.7, it's normal. If it's less than 0.7, when you do the ratio, the toe brachial index, you know, you take the pressure of the toe divided by the pressure of the brachial artery, and that's going to give you that reading. Okay, here we go. Toe brachial index for reliable data. Okay, so this is the range. Greater than 0.7 is normal. 0 to 0.5 to 0.7 is mild. 0.35 to 0.5 is moderate. Less than 0.35. Moderate to severe, less than 0.35 is severe with these toe pressures, okay? Toe pressures 40 millimeters of mercury and less than 30 millimeters of mercury. And this comes from Mayo Clinic Vascular Lab. Here is a Doppler waveform. So here is a classic triphasic Doppler signal, okay? You see my arrow on the screen? So this is the initiation of the waveform. This is the amplitude of the waveform, okay? This is the crest and this is the trough. And so as you see here, this is your first waveform, your second waveform, and your third waveform. Back to baseline, first waveform, second waveform, third waveform, triphasic, okay? Abnormal waveforms, you lose the triphasic waveform. So here, you've noticed that the amplitude is probably not as big. This still looks like a kind of a triphasic waveform, but it's not. These are all abnormal waveforms. And if you look at this one here on the bottom of the screen, this is more of a monophasic waveform, okay? Just one waveform. There's no trough, there's just a crest, and then it keeps going on. And that's because that vessel has lost its flexibility and there's very little flow coming down there. Dampening of amplitude and slow upstroke, okay? It's like this. This is kind of abnormal because it's not straight up like you saw in the previous one, okay? ABI interpretation, I think we went through this again, but we can do it again. 0.92 normal and above, 0.5, 0.91. Patients usually will have claudication. Rest pain presents anything less than 0.5. And then ulcerations will happen if the ABI is less than 0.3 or 0.3. And then you have non-compressible vessels. Toe pressures, as we discussed before, greater than 20 for non-diabetics, greater than 40 for diabetics. And that is to kind of determine if they're going to heal their wound or not. So somebody who's got an ulcer and is non-diabetic, they need 20 millimeters of mercury of pressure in those toes to heal their wounds. And if they're a diabetic, they need greater than 40 millimeters of mercury, okay? On physical examination, what do you find? Decreased femoral pulses. I think this is redundant. So the diagnosis of PVD after you have your clinical suspicion, which 80% of your clinical assessment or impression should be done by your clinical examination, okay? The 20% remainder is confirmatory. It's to confirm your diagnosis. That's why medicine is an art. And the art of medicine is being able to look at a patient, touch the patient, you know, inspect the patient and come up with your clinical diagnosis based on all the data that you gather. You are a detective. You are Sherlock Holmes, okay? And Sherlock Holmes confirms this theory based on, you know, what his clinical findings were of his assessment of the crime scene. Then he confirms it by doing all these little tests, right? And that's 20% of it. So your 20% is confirmed by arterial duplex ultrasonography, angiography, CT angiography, and MRAs, okay? This is an angiogram, and you can see here the popliteal artery. You see the geniculate collaterals coming off the infrapopliteal artery. Then you see the anterior tibial artery, and there's a stenosis in the anterior tibial artery here. And there's the tibioperineal trunk with stenosis in multiple levels in the tibioperineal trunk. And the posterior tibial that comes along here, it's gone. And this is the perineal artery that has multiple levels of stenosis. So this patient probably has critical limb ischemia and is one step from losing the limb. And these things here can be repaired by an endovascular procedure. This is a classic normal arterial duplex. You can see here the color flow beautifully through this vessel with minimal enhancement of the walls. This is completely normal. And you have your triphasic Doppler signals, okay? And this also gives you a spectral analysis of that Doppler signal. This looks pretty normal. This is an abnormal arterial duplex. You can see here there's loss of the triphasic Doppler waveform. And this is a right femoral artery distal stenosis. You can see a color flow analysis here. This also here, this waveform, this is a spectral analysis that evaluates velocity. So from one crest to another crest, you can measure the velocity of flow. Okay. I'm sorry, this is the wavelength. The velocity of flow is going to be measured how high the amplitude is. So over here, you could see that the velocity A in this patient is 327.5 centimeters per second. Now, my analogy that I always give my patients when I'm explaining to them how we measure velocities through an artery by ultrasound is the higher the velocity, the higher the grade of stenosis, okay? So if you take a water hose, right, without your sprinkler thing at the end of the water hose, and you take your thumb and you squeeze at the end of that water hose, that water is gonna squirt, right? You're increasing the velocity of that water. So can you imagine watering your grandmother's rose garden with a spray of water? You'd be there forever. You'd never get the blood flow. You'd never get the water, you know, to completely saturate the roses. But if you take your thumb off of it and you lay the water hose next to all the roses, you're going to water that garden very fast, right? Same thing happens in us. If our pipes are narrowed, the velocity increases. And after that velocity increase, there is a drop of pressure beyond that. Okay. Usually what happens is you'll see somebody that goes from 50 centimeters per second into their stenosis to 350 centimeters per second. And if you get the ratio between the two, the ratio is greater than 2. okay? If the ratio is greater than 2, the stenosis grade is greater than 50%. The higher the velocity, the greater the stenosis. And eventually, the velocity just disappears because you get a blocked artery, okay? All right, this is the task 2 classification for proximal disease. These are a representation of the distal aorta, the common iliacs, internal iliacs, external iliac arteries. Okay, and this classification of task 2 talks about type A lesions, type B lesions, and type C lesions. And there's another one. Type A lesions are usually unilateral or bilateral stenosis of the common iliac arteries, okay? So unilateral or bilateral, okay? Unilateral or bilateral, single short, less than 3 centimeter stenosis of the external iliac arteries. That's a type A lesion. A type B lesion is a short lesion less than 3 centimeters.
You need some security code from King.
Oh, hold on a second. Yeah. I don't see it. Did she send me an email? Sorry, guys. Hang on one second for me.
Said to J. Antezana, but I don't.
We were in task B lesions. So short, less than 3 centimeters, stenosis of the infra aorta. So you can see here this image that I'm showing you with my pointer. There's an infrarenal stenosis. Unilateral common iliac artery occlusion. Okay, so a type B lesion will have an occlusion of the common iliac artery on either side, or a tight stenosis below the renal arteries. A single or multiple stenosis totaling 3 to 10 centimeters involving the external iliac artery, not extending into the common femoral artery, as you can see in this depiction right here. Okay. A type C lesion, these task classification help you determine what you're going to do for this patient. Okay. What level of treatment, whether it's going to be an open revascularization of the distal aorta, or you can do a angioplasty and stenting of these. A type C lesion, you can have bilateral common iliac artery occlusions. You can have bilateral external iliac artery stenosis ranging from 3 to 10 centimeters long, not extending into the common femoral artery. A unilateral external iliac artery stenosis extending into the common femoral artery, like you see in this image. A unilateral external iliac artery occlusion that involves the origins of the internal and external iliac arteries, or down to the common femoral artery. A heavily calcified unilateral external iliac artery occlusion with or without involvement of the origins of the internal iliac and or the common femoral artery. So the depiction here, these are the common femoral arteries. These are the external iliac arteries, the internal iliac arteries, the common iliac arteries, and the distal aorta. Okay, everybody got that? All right, class 2 for SFA. So TASC also has classification for superficial femoral artery disease. And this is more what we do. I mean, we do see a lot of iliac artery disease and we address, but not as much as superficial femoral artery disease. A class 2 type A is a single occlusion less than 5 centimeters in length. Type B is a single occlusion less than 5 centimeters, but heavily calcified, or multiple occlusions, each less than 5 centimeters, or a single occlusion less than 15 centimeters, okay? A type C is multiple occlusions greater than 15 centimeters, and a type D is chronic total occlusion greater than 20 centimeters. So for for the types C and D, the recommendation is usually a bypass surgery, but how can you do a bypass surgery on a patient with an ejection fraction of 20, with multiple myocardial infarctions, and won't tolerate a general anesthetic or a spinal anesthetic? So in these cases, the type C and type D, many times we will address in an ambulatory setting in the cath lab, and we would do atherectomy and angioplasty. These procedures can be done under a local anesthesia, obviating the need of general anesthesia or spinal anesthesia with their subsequent complications on a patient that's critically ill like this, okay? How do you treat PVD? Well, first, it's medical therapy. As much as we love surgery and we want to cut people up, we don't want to instill surgical therapy as a first line of treatment. Medical therapy. Patient smokes, this needs to happen. Stop smoking. Patient needs to understand if they don't stop smoking, they're going to lose their limb, and you're not going to offer them surgery. Sometimes you even have to threaten the patient that you're not going to touch them and you're not going to keep them as your patient if they don't stop smoking. How do you check if they have stopped smoking? You can't sometimes just trust the patient, but you can order a blood test called a coteen test, right? Have you guys heard of that? A coteen. So you order a coteen test, and it tells you if the patient was smoking, because they're going to have the breakdown particles of nicotine. Okay, a coteen test. You put them in a walking program. Physical therapy is very important. This is where you can help our different physical therapy programs that our community offers and send patients, to a walking program, or you educate them and incentivize them that they need to walk for at least 30 minutes every day, because walking, even if a patient has a significant blockage in the superficial femoral artery or even the iliac artery, you can stimulate that patient's development of collateral blood circulation. In one of the images in the back, I mentioned infrapopliteal geniculates. You guys remember that? Those geniculates are suprapopliteal and infrapopliteal. Those are collaterals that come off of the main vessel, off the popliteal artery and from the SFA, and connect with the profunda femoral artery. If these patients are compliant and they follow an exercise regimen where they can walk, they can develop collateral blood circulation. Okay. Pharmacological therapy can also be instilled by the use of Platol. Platol is also known as silostazol. This is a carbonic anhydrase inhibitor that you can use to stimulate increased blood flow into a patient with peripheral arterial occlusive disease. It's a great drug. We start these patients and we treat them for 30 days. Now we treat them for 90 days with conservative management. Stop smoking, walking, and Platol. And we get them walking, and so they can develop collateral blood circulation. And we follow them up in our vascular lab with ultrasounds to see if they have improvement. Other antiplatelet aggregants are also important. The use of 81 milligrams of baby aspirin, or the use of Plavix, also known as clopidogrel, at a dose of 75 milligrams daily. The Platol dose, or silostazol, we usually give 100 milligrams PO twice a day, or you can do a 50 milligram PO twice a day for the patients that are elderly. You have to remember one important thing when you're giving Platol is that patients with congestive heart failure will exacerbate their symptoms if you give them Platol. So be careful with patients with congestive heart failure and the use of silostazol, okay? The use of statins. Statins are very important to manage hyperlipidemia. Statins and a good diet with rich in green vegetables is important to help maintain a good, healthy cholesterol. Cholesterol is not bad for you, right? People think of cholesterol and they say, oh no, yeah, I've got cholesterol. We all have cholesterol. If we didn't have cholesterol, we wouldn't be able to make hormones. We wouldn't be able to, sustain, cellular life and metabolism. So we need cholesterol in our diets. That's why HDLs are very important. HDLs are so important to help us mobilize the bad cholesterol out of our system. Our diets are very crucial and very important. One of the things that I add to my regimen of conservative medical therapy in my patients with hyperlipidemia and diabetes, and not just those, even the patients that just smoke and don't have any other conditions except atherosclerosis, is the use of cinnamon. Cinnamon is not just something to spice up your food, but it really spices up your life. And I want you guys to understand the properties of cinnamon. And next time we're on, we'll discuss it. And I want you guys to tell me all about cinnamon. Why is Dr. Antezana so much of a fan of cinnamon for his patients with vascular disease? Okay, cinnamon is a great spice. And I won't go into details because I want you guys to be curious and find out. Risk factor management. When you say risk factor management or management of risk factors, you talk about diabetes control, hypertension control, hyperlipidemic control. Okay, diet, etc. Foot care, the use of adequate shoes that do not cause pressure over certain parts of the feet is important, and moisturizing the skin so the skin does not break apart easily. So the treatment of PVD, again, medical therapy is first line. Open surgery is an option, and then endovascular repair. So the controversy of open surgery versus endovascular surgery depends on the criteria of each physician and also the level of comfort. As a vascular surgeon, if I have a patient that's relatively young and has good targets, both inflow and outflow, then I may select to do a minimum to do a bypass surgery. If I see that the disease is very isolated, very easy, and this is an active person, I also give them the choice of an endovascular approach. If they follow my instruction, the endovascular approach can last them for the rest of their life. If they quit smoking, if they have their diabetes controlled, if they are diabetic, and if they have hyperlipidemia and hypertension. If these factors are modified and controlled, an endovascular surgery should last the patient. But the gold standard still remains an open bypass surgery to repair these patients, okay? So this is a depiction of how we splay a vessel open and perform an anastomosis, doing the back wall first and then the anterior wall. This also is a great translation of our art as surgeons, or a depiction. So surgical revascularization for aortoiliac disease. See, the patency for aortoiliac surgery when you're doing an aortobifemoral is excellent. These will last the patient for pretty much the rest of their lives, if and then they become compliant to all your instructions. That's the problem. I never forget when I was a apprentice to a vascular surgeon in Florida, and I worked with him for a year before I started my residency. We did a very, very complex aortobifemoral bypass procedure for severe aortoiliac disease. And this patient, the day that he was discharged, was walking out of the hospital with a cigarette in his mouth. And I was just appalled. I mean, I was like, oh my goodness. We just spent 4 hours fixing this guy. He had a 2-day stay in the ICU and a 3-day stay on the ward, and he gets discharged and he picks up his freaking cigarettes again. Amazing. Well, anyway, so excellent patency with aortoiliac bypass. The operative mortality is 3.3%. You know, it's there, you know, you're opening the patient's belly and the possibility of a complication can occur. Perioperative mortality, 8.3%. So this is not a safe, you know, procedure. An endovascular surgery to reconstruct an aortoiliac, that if it's feasible, the complication rates of that are less than 2%. All right, so PTA of iliac arteries. And here we go, technical success from the different authors of compared to a aortofemoral bypass or aortoiliac bypass. You've got 5 different authors, and everybody's technical success is pretty good, 78%, 82, 81, and then Bloom in 1993 had 98% success rate. So it is feasible to do an endovascular surgery and have success. This is the Palmas and Sullivan's results in 1992, 1-year patency rate for stents, 92% and 97. Sullivan had a 2-year patency rate of 84%. So you guys can see that the results are very good for endovascular surgery. And it doesn't eliminate the possibility of doing an aortobifem in the future. Okay, so the stents can be removed, the stents can be bypassed above and below, etc. So PTA versus stenting. So the controversy in the beginning was, what do? We just angioplasty of the vessels, or we stent them as well? So angioplasty alone was only 69% in 4-year patency, which is not bad. But if you put stents in there, you'll get 94% patency. So it's better to stent an iliac vessel than to just do an angioplasty. Okay. Here is a angiogram of a totally occluded right common external iliac, and there is no reconstitution of flow down here in the common femoral. But what's interesting in here is that this is a reconstruction. You know, this is a bypass surgery. All right, so this is the bypass that goes all the way down from looks like it's coming off the common iliac artery. Can you guys see that? So this is what a bypass looks like, okay? This is a huge collateral artery right here. And you would think that this is part of the external iliac artery, and this is the common, this is not. This is a collateral coming off the sacral artery. This is a sacral artery collateral that's filling down here. It's amazing. So this patient is probably pretty active, had a complete blockage of both iliac arteries, and they just did a aorto, probably it's coming from the aorta, and an aorto femoral bypass. And I think, let me see here. So I believe this is the same patient that came in for revascularization. So you could see completely occluded, okay? This is where that limb was. And this patient here, we crossed the whole lesion of his native vessel, came in through there, and then reconstructed the whole vessel. We put two kissing stents. This is how you put two kissing stents, and you put the stents, and these are self-expanding stents. Usually we will put balloon expandable stents, but here we put two self-expanding self-expanding stents, and then we took two balloons and did a kissing technique to reconstruct the distal aortic bifurcation. So at the end of the surgery, this is what it looked like. So native vessel looks pretty clean, full of stents. Here's the sacral, the large sacral vessel, and here is the reconstruction of the right side. This probably will need further stenting, but this was a classic case just to show you that these are completely doable cases without having to open up the person and subject them to that 3 to 4% mortality, right? Operative mortality, or that almost 9% perioperative mortality. So this is a distal SFA at the adductor canal with severe stenosis. You can see the shadowing of the calcification in this side. This is the lumen. So this patient probably had severe claudication just based on what we're looking at here. And further down, we don't know what this looks like, but I'm sure there's some disease there as well. So this is just a simple balloon angioplasty, and it looks great. Usually these simple balloon angioplasties won't last very long. Their patency rates are not very good, and you'll have to come back and do atherectomy and possibly stenting. Sometimes you can get away with just atherectomy and then angioplasty, even without stenting, and you'll have a longer patency rate. So here is a infrapopliteal view. You got the popliteal artery. You have an anterior tibial artery that's completely occluded just beyond its origin. Tight stenosis at the ostia. You've got tibioperineal trunk disease. You got a posterior tibial artery that's severely diseased, and you got a perineal artery that's also severely diseased but looks to be patent. So this one, we went down the perineal artery to fix the TPT trunk and the perineal. We like to use intravascular ultrasonography. So believe it or not, ultrasound technology has evolved to the point where we have the technology at the tip of a millimeter catheter. Okay, so the IVUS catheter is about 1 millimeter in diameter. It's sent down over a small 014 wire, and you can see the inside of the vessel like you see in this depiction. Here's a normal looking vessel. This is the IVUS, the intravascular ultrasound. And here we go. Here is the normal wall of the vessel, and this is all the plaque buildup. This is all atherosclerosis. You guys can see deposits of calcium within the wall. And then it's more of a heterogeneous plaque formation, which means that it's got hyperdense and hypodense tissue. Hypodense, the black; hyperdense, the whiter, okay? This is very important when you're doing an intervention in the lower extremities and you want to make sure that the patient had an adequate atherectomy and angioplasty. And sometimes you need to put stents, you know, in the areas that are identified as areas that may cause problems, like dissections or flaps that, you know, are coming off the wall that could be a nidus for a clot, etc. That's why IVUS is so important. Volcano is also used, volcanoitis is also used for coronary arteries, but now we're starting to do a lot more peripheral, and they come in different sizes. So we can also do venous intravascular ultrasound or arterial. For the venous, the catheter is bigger, it goes through a larger wire, and you have a better view. Okay, let's see. So FEMPOP and tibial summary. Focal disease. If you have focal disease, we usually recommend endovascular therapy. For more complex disease, if the patient is a good risk, which means that the comorbidities are either well controlled or have very low comorbidities, surgical revascularization with bypass is feasible, it's possible. There's also something called a hybrid approach to peripheral vascular disease, where you can do a combination of endovascular and open surgical techniques to work on your patient, especially when you have multi-level disease. Let's say a patient with proximal iliac artery stenosis that you want to do a FEMPOP because they have a 20 centimeter superficial femoral artery occlusion. You expose the femoral groin, the femoral artery, you go up, you stent the common iliac artery, then you do your bypass from the common femoral to beyond the occlusion into a adequate vessel, which could be in this case a above the knee popliteal or an infra knee popliteal. If the patient is poor risk and you don't want to subject the patient to anesthesia, then you do a purely endovascular approach. Let's see. All right, and that's it. You guys have any questions for me?
Yeah, I have a question. In which patients do we do an angioplasty instead of going directly to stenting, because it has a higher relapse of the artery doing the stenting?
So what I do in my practice is, if I go in and I do an angiogram and the stenosis is not very calcified and the plaque burden is not that great, I will do angioplasty alone. Okay. And I confirm not just with angiography, but I also use intravascular ultrasound. The angiography only gives you it only will give you a two-dimensional view, right? Compared to, a two-dimensional view compared to your third dimension, which I call the intravascular ultrasound dimension. So when you put an intravascular ultrasound inside that vessel, you're looking at the vessel on the inside versus a two-dimensional view that's coming through here and coming out of this way, right, with x-rays. So that third dimension allows you to make that determination whether the plaque is heterogeneous, homogeneous, and if the plaque burden is large or small. If the plaque burden is large, I know that if I do a balloon and expand that balloon, with time, there's going to be a recoil of that because of the elasticity in the vessel. So in that case, I put in a stent, and that stent scaffolds, and I might have a stent here that I can show you guys. That stent will scaffold that vessel open. Looks like they took my stents out of here, but I'll have some more to show you guys in the near future. So the stent essentially scaffolds that vessel from, retracting back, recoiling back, and causing stenosis. So that's when I would do it. Depending on the plaque, morphology, the amount of plaque burden left after atherectomy. And when we do these procedures, we take devices that literally take the plaque out, either by rotablation, okay? It's called atherectomy, endoatherectomy, and we have a laser atherectomy device. We have a laser atherectomy device. We have a orbital atherectomy device that kind of files that plaque down and makes microparticles that go distally into the foot. And then after we decrease the plaque burden, we'll go in there and we'll put a stent in. Okay, any other questions? Nope. Did you guys, it's vascular disease is fascinating. I love what I do, and it's so rewarding. I've got so many things to show and share with you guys and discuss, and we'll do that later on. I think we've are almost done with our time. I've got patients in about 15 more minutes. So I don't know when I'm going to be on next, but I want you guys to tell me what you want to do next. okay? I think peripheral vascular disease and what we've talked about is very important. I think just to make a recap, your clinical assessment is of utmost importance, because when you touch that patient and you examine the patient and you find vascular disease, you can help mitigate the progression of that by risk factor modification, helping the patient, one, understand his disease, two, convey that information to the primary care physician so you can co-manage the patient and treat the hypertension, treat the high cholesterol, treat the diabetes, you know, put the patient in a walking program and a structured exercise program so they can develop more collateral blood flow in the lower extremities to prevent their limb loss. Remember, the objective is we want people to walk into the kingdom of heaven on two legs. We don't want them to roll into the kingdom of heaven. That's what I tell my patients. Any other questions?
Doctor, una pregunta. Por lo menos en estos pacientes, cuando se le hace, por lo menos en bypass o en los stents, ¿hay algún riesgo de reincidencia de estenosis o de claudicación?
Definitivamente, claro que sí. Sí, la estenosis, la fisiología del flujo de sangre, para que un vaso arterial se quede abierto, ¿no? Es importante de que el outflow, que la sangre tenga un fin prolongado, que no haya una resistencia vascular periférica elevada. Los pacientes que tienen recidiva, que tienen progresión de su enfermedad o que los stents se les van a ocluir, son pacientes que por lo generalmente no están siendo, no se están comportando a las recomendaciones de su médico. Continúan fumando, tienen una diabetes que está pobremente controlada, no hacen ejercicios y demás. Entonces va a haber progreso de la enfermedad. Usualmente, el progreso de la enfermedad, ya sea por bypass surgery o por stenting, es a 2 años. Si antes de 2 años el paciente desarrolla un problema, es generalmente en los stents, que se crea lo que se llama una neointimal hyperplasia, hiperplasia neointimal. ¿No? En otras palabras, la íntima, se crea un nuevo íntima porque hay una migración de células musculares lisas que van tapizando el interior de estos stents y los van ocluyendo. Entonces, la placa no, dentro de los stents no es una placa como se ve normalmente. Son células musculares lisas que están tapizando y van creando una estrechez de la arteria. La manera que se comporta cada cuerpo humano es un poquito distinto. Algunos no tienen esa reacción y otros sí tienen esa reacción y tienes que volver a entrar al stent y usar un láser para hacer evaporar esa placa que está creciendo dentro del stent. Por lo general, depende de el nivel de la enfermedad. Si es una enfermedad en múltiples niveles de las arterias, ya sea de la arteria femoral superficial, común o las tibiales, no depende de qué severa es la enfermedad para la longevidad del tratamiento. Si la enfermedad es bien severa y de múltiples niveles, entonces puede ser que el tratamiento no dure mucho tiempo. Por eso es que nosotros, no solamente cuando le operamos al paciente, no, ya lo dejamos de ver. No, uno tiene que hacer un seguimiento de ese paciente continuamente. No, el seguimiento que nosotros hacemos es con puro ultrasonografía. Tenemos un laboratorio de ultrasonografía que hace el seguimiento a las 2 semanas después de la intervención para tener una nueva base, después al mes, después a los 3 meses y después a los 6 meses y después el resto de la vida del paciente son cada 6 meses hasta que encontremos un problema. Esto se llama vascular surveillance. Uno está haciendo un screening vascular periódico para seguir la enfermedad que va a progresar, porque estos pacientes generalmente van a tener progreso de la enfermedad. Espero que haya contestado.
Listo, muchas gracias, doctor.
De nada. ¿Alguien más?
Doctor,
Uh-huh.
okay. Entonces, en estos casos donde los pacientes estén en 2B y progresen no, que estén en 2A y vayan progresando, ¿cuánto es la posibilidad de que lleguen hasta una etapa 3?
Eso es es por eso que nosotros tenemos la tarea de vigilar. Tenemos que vigilar a estos pacientes para que no lleguen a un estadio o una categoría 3, ¿no? O más allá. Entonces, nosotros tenemos que hacer la vigilia de estos pacientes. Primero, tenemos que identificar que tienen una enfermedad periférica vascular. Educar, manejo médico y el seguimiento. Una vez que pierdes el paciente del seguimiento y ese paciente regresa a las costumbres y hábitos inadecuados que van a hacer que su enfermedad progrese, muy probablemente que ese paciente termine en la sala de emergencias con una pierna fría, ¿no? Con una isquemia aguda, entonces la tengas que ver en la sala de emergencias. Pero es importante, ¿no? Educar al paciente, concientizar al paciente para que ese paciente continúe viniendo a tu clínica y tú puedas vigilar su progreso de su enfermedad. Ellos progresan si la enfermedad no está, si todas las comorbilidades no están controladas, ¿no?
Ok, muchas gracias.
No, de nada. ¿Algo más, jóvenes?
Doctor, una pregunta. En estos casos en los que se entra con el láser que usted había comentado para remover la placa, ¿corre el riesgo de que se pueda hacer alguna lesión en el vaso y se tenga que cambiar el tipo de cirugía?
Sí, así, la verdad que sí, mucho, la técnica endovascular es muy dependiente del operador. Hay operadores que son muy buenos y las complicaciones son menos del 0.01% en mi caso, y hay personas que no conocen muy bien y se ponen a hacer una aterectomía y están en un plano subíntimo. Y un plano subíntimo puede causar una perforación de la arteria. Entonces, cuando yo hablo de un plano subintimal plane, estoy hablando de un plano que está más allá de la media, que está debajo de la adventicia de la arteria. Entonces, está entre la media y la adventicia. Si tú pones un láser por ahí, va a destrozar el tejido y eso va a causarle al paciente mucho dolor y le va a causar una perforación. Pero mientras tú tengas el alambre atravesado y distalmente plantado en el pie o en la parte distal de la pierna, tú puedes salvar la situación. Pero por eso que el ultrasonido endovascular es muy importante, porque te va a decir dónde te encuentras, en qué parte de la arteria te encuentras. Sí puede haber una complicación. Lo más común cuando uno usa un láser es que pueda haber un desprendimiento de una placa ateromatosa y se vaya distalmente y cause una trombosis, ¿no? No trombosis, una embolia distal. Entonces te estás encontrando persiguiendo a ese émbolo para extraer al émbolo manualmente o obliterarlo con tu láser de nuevo.
Ok, gracias.
De nada. ¿Algo más, chicos? Bueno, creo que con esto concluimos la primera charla sobre enfermedad periférica vascular. Juliet, ¿me avisas qué podemos hacer la siguiente? ¿No? Podemos, la próxima clase tal vez podamos ver distintos casos de enfermedad periférica vascular y la manera que uno aborda los casos para repararlos, porque no solamente uno puede entrar por la ingle, a la arteria femoral, pero también se puede entrar por la poplitea o se puede entrar por la arteria braquial, ¿no? O se puede entrar por el pie para salvar estas piernas. Y es ahí donde se vuelve bien interesante porque la creatividad del ser humano se pone en juego cuando uno quiere y tiene la intención de salvar la pierna de una persona. Ok, bueno, un gusto.